Hey guys, thanks for joining up with me this week to talk about a case on Master Your Medics. Now, pilots use a term called dynamic instability to describe an unstable flight path, right? So they use this term called dynamic instability in aviation, but I use the same term to describe, an ECG that is a harbinger of bad things to come. Let's go ahead and take a look at today's case and see how this applies. Okay, so this was a 52-year-old female with the chief complaint of left anterior chest pain. Now, the pain was reproducible with palpation over the fifth rib, and she had no other symptoms. She did admit to not having seen her primary care physician for several years. And on arrival, well, she was really quite anxious appearing. Her blood pressure was elevated, and the rest of her vital signs were reasonably well. Now, like we always do, we immediately get an ECG in a patient like this, and here's her first 12-lead ECG. Go ahead and stop the video here and see if you can interpret this ECG. So, as I always recommend, always take time to go through a quick, systematic way of looking at the ECG to make sure you pick out any serious abnormalities, and it doesn't take very long. So let's go ahead and take a look at this particular one. The one I always first look at is structural integrity, and that is, do the different waves there, are there waves, the P wave, QRS, and T wave, do they make sense? Are they in sort of good relationship to each other? And in fact, they are. The rate was 66, the rhythm sinus axis was normal, the intervals were the normal limits also, and the ST segments, well, there's some slight, very subtle differences. We'll talk about that soon. The T waves, well, the T waves seem symmetrical, not huge, but very symmetrical, and a positive T wave in V1 that I never like to see. The voltage appeared to be normal, and extra waves, well, not really. And dynamic instability, well, this was concerning enough to us that we had to go ahead and get another ECG. Now, remember that the computer is calling this sinus rhythm with inferior ST abnormalities that are nonspecific. Now, what that means is that the elevations or depressions are less than 1 millimeter, not quite STEMI criteria, right? So let's go ahead and blow up the inferior leads and, bang, there's some depressions in these leads here that are very subtle. And are there reciprocal changes? Well, take a look at AVL. AVL does show some elevations, and blowing AVL up, in fact, you can see that if this is the baseline here, the TP segment, there's the J point, and the elevations and the ST segment is in fact elevated. So the patient actually was in the ED. Her daughter came about 30 minutes later and expressed concerns about her mother's symptoms, saying that, her mother never complains, and this just isn't right for her. And that she's been complaining of not feeling well for the past 1 week or so. So quite concerning. And like I said before, whenever you see a suspicious ECG, always get a second one to see how it's changing, right? And so getting the second ECG about 20 minutes later showed this. And now the computer has changed its tune. It's calling this sinus rhythm with anterolateral ST elevations and asking you to consider an acute MI. And in fact, when you look at this, I see straightening of V2. The ST segments are straight, very, very straight, and all these anterior and lateral precordial leads. And looking at AVL, where there's more elevations here with depressions in the inferior leads, right? I don't like this one darn bit. And now, 20 minutes later, the patient developed worsening chest pain. She became profoundly diaphoretic and ill. And guess what happened? She tanks her blood pressure. Everyone acted quickly. The STEMI checklist came out, and she quickly had another ECG as we were prepping her for the cath lab. And here's what it showed. This is, again, those straightening segments of the ST segments in the anterior precordial leads and the lateral leads are now even worse. Now we just have tombstones, right? And this all occurred over, within 50 minutes or so. And now you see elevations here in AVL and even more depressions in the inferior leads, the reciprocal leads. So Dynamic instability. It's something that we see in ECGs. Whenever you see a patient with a suspicious looking ECG initially, always get another one. Here's again to review. The initial ECG showed, concaving ST segments. There's the J point, really nothing terribly concerning except for those other very subtle changes we talked about earlier on in AVL and V1, right? V1 should never be positive, right? It should be negative or isoelectric. And this is 30 minutes later, where you see the J point being elevated. The straightening of the ST segments, always a dangerous thing to see. And the third one, about 50 minutes later in total time, showing, frank tombstones of the QRS, the ST segments rather. So concave progressing on to ST segment straightening, and then progressing on to tombstones. Dynamic instability. Hospital course was, she went immediately to the cath lab, had 100% LAD occlusion and a mid LAD occlusion also, got stents, admitted to the ICU, and did just fine, thankfully. Now, the take-home points, just 2 take-home points that I'll press on you folks to remember, and that is dynamic instability is an ominous sign. When you see things changing on the ECG, always get a second or third ECG to see whether or not this is a STEMI in evolution, right? And when patients come in with, palpation tenderness, things that seem to be non-cardiac, when they have risk factors, especially when they have risk factors, always just get a second ECG. All right, so thanks so much for joining me in this case today. Leave your questions and comments. Would love to hear from you. Until next week, take care.